now I will introduce another project that is a perspective on the recently published work that, as we all know, is also about regarding the neuroprotection therapy in the field of acute ischemic stroke patients who were treated with endovascular thrombectomy. And the clinical question is also that although the endovascular thrombectomy can achieve a high rate of recanalization, especially for patients with large vessel occlusion, and but the functional outcomes of the patients who were treated with thrombectomy was not as good as we expected. And for example, the functional independence is less than 50%, and the excellent outcome is only less than 30%. So how can we improve how can we further improve the prognosis of these part of patients who are treated with thrombectomy is a very important clinical question, especially in the field of ischemic stroke. And in this field, a lot of review and projects have been tacked on this question. And in the Frontiers trial, and we can see that a new neuroprotection agent has been used to test whether the NA1 can improve the functional outcome of these part of patients. And as we all know that the NA1 is a very famous neuroprotection agents in the field of acute ischemic stroke, and several clinical trials have been published, such as the Escape NA1 but unfortunately, the trial didn't find that in patients who were treated with endovascular thrombectomy, NA1 can benefit these part of patients. And based on the clinical trial, the NA1 next also targeted on patients who were not treated with intravenous thrombolysis, the subgroup patients. But unfortunately, the Escape next also didn't find any beneficial of NA1. And based on the several previous clinical trials, the Frontier trial also launched to investigate whether the NA1 that was administered early in the patients who were suspected of large vessel occlusion, acute ischemic stroke. And but in this trial, there's also the result was also neutral, but didn't demonstrate that the functional benefits of NA1 in patients who were suspected of large vessel occlusion and treated with endovascular thrombectomy eventually. And we can see that there's also some other neuroprotection therapy that like NA1, but the NA1 has been regarded as the most promising neuroprotection agents in the field of acute ischemic stroke. But the several neutral results of the NA1 is also very surprising in this therapy field, and to some extent, it's also disappointing. And I think that there are many questions we should do to further improve how can we use the neuroprotection to improve the functional outcome of patients who are treated with thrombectomy. And the first question is how and when we start use the when we initiation of the neuroprotection therapy, and the most promising therapy time points is maybe before the evaluation of the large infection has been large infection volume has been formation has been developed, because in the published clinical trials, and we found that even patients who are treated with neuroprotection and who are treated with thrombectomy, and lots of them has a large infection score finally, and in this part of patients, maybe the large infection score that has been developed that can cause a very severe deficits and even cause mortality. And the second question is which neuroprotection therapy or neuroprotective agents should we use? And now the NE1 has been demonstrated to be a neutral benefits in patients with stroke, and this drug has been considered as the most promising neuroprotection therapy, and in the future, and we should investigate other neuroprotection therapies. Maybe the neuroprotection target on multiple mechanisms of acute ischemic stroke injury. Maybe can play a better role than the agents that only target on one or two the signals or the targets of the injury. And also there's the third question is in which phase of the acute ischemic stroke or can we use the neuroprotection therapy? And recently, or in the previous published clinical trials, we only used the neuroprotection therapy in the acute phase, and maybe only once or several times. Maybe this is not enough, as we all know that the acute ischemic stroke causes the ischemic injury, and the injury lasts for a long time. And the most intense change is during the first several hours, but after the several hours later, and the injury maybe also lasts for a long time, and the recovery of the ischemic injury also lasts for a long time. So maybe in different phases of acute ischemic stroke, we should use different therapies and different neuroprotective agents and neuroprotective strategies. And so if we use the frontier trials, although the frontier trials get neutral results, and in the future it provided a very helpful guidance for future clinical trials, and in future neuroprotection future clinical trials that investigate the neuroprotective agents or neuroprotective therapies, and we can consider more comprehensive strategies to improve the patients who are treated with thrombectomy. Maybe with these strategies or with these steps, we can finally use the neuroprotection to improve the functional outcome of patients who are treated with thrombectomy.